Dr. Ehrenberger is Chief Medical Officer for Avista Adventist Hospital and for Centura Health's Integrated Physician Network, an accountable care organization north of Denver. He has had 7 years experience leading a community clinical integration collaborative in North Metro at Denver. He is a partner in a 14-provider family practice, recognized as Level 3 patient-centered medical home now for 3 years. So his practice was definitely on the bleeding edge of patient-centered medical home and an innovator by definition. Leadership around patient-centered medical home and transformation has been a central theme in Dr. Ehrenberger's work. He's Vice President of Health Teamworks in Denver, which convened Colorado's successful multi-stakeholder, multi-payer, patient-centered medical home pilot. He is a board member of the Colorado Foundation for Medical Care, the state of Colorado's QIO. Dr. Ehrenberger is viewed as a national leader on medical home and on the use of technology to advance patient-centered care. He's going to discuss keeping the main thing this morning. So please welcome Dr. David Ehrenberger to our stage.
Thank you. Hopefully this is picking up okay. Given that I have 15 minutes to complete my half-an-hour presentation, you'll be pleased to know that I just last week completed my Evelyn Wood speed speaking course, so I think we're all good. And I have to say it's a little intimidating coming to Cincinnati, particularly after hearing Keith Hepp brag incessantly about Cincinnati and how great it is, because given that perspective, you know, I'm from Colorado. I mean, it's a third world country, so I don't know why I'm here, quite frankly. But nevertheless, I'll give it my best shot, speed speaking style. So keeping the main thing the main thing. So the main thing, of course, is exceptional care, right? That's the theme of this concert or conference, if you all have been paying attention. The exceptional care, and this is kind of a little nod to Craig, wherever Craig went to, insofar as you get to exceptional care through things, tools, foundations like PCMH and meaningful use and that kind of stuff. But first, I wanted to kind of delve into exceptional care. Trudy challenged me to do that. And what is the connection between these elemental foundations, and exceptional care? So I'm going to draw on my own experience about this. And I'm going to do a little Rod Serling moment here, Twilight Zone, you know, imagine if you will, for all those who are history buffs or as old as I am, you can remember that kind of stuff. But really to kind of paint the picture of what exceptional care is like from the viewpoint of patients, and also from providers and their staff. So I'm going to get to that in just a second. I'm also going to be addressing my own journey toward exceptional care. Not there yet, but aim to get there. And I'm going to relate two stories. A patient by the name of Jim, who's a real patient of mine, I've had for a long time, and I'm going to relate his story from the beginning of the journey, to reflect the beginning of the journey, and then I'm going to talk about Reuben. And his example will be what exceptional care, or at least where I'm at in my practice, is all about now. Along the way, I'm going to talk about the LA Police Department. I'll get to that later. I'm sure you'll see the connection. And so let's talk about this what-if scenario, and just imagine healthcare like this. So imagine you're a patient, and you walk in the office of your primary care team, and everybody really knows you and knows what you need, even before perhaps you do. What if your health was as important to your healthcare team between visits as it is at the time of your visit? And then what if at every visit your provider was relaxed and seemed to have plenty of time to listen, to understand, and to connect? It's getting a little crazy, I know. What if after an office visit you consistently felt better informed and energized to promote your own health? And what if your elderly grandparent, living alone yet frail, could count on her care team making home visits? How about the provider view? So what if a busy PCP, primary care provider, patient load for a day was 8 patients, or maybe 10, a maximum of 12 every day? And what if each PCP was supported by a team of 2 MAs, and the MAs did as much clinical work as the provider, not just blood pressures? What if pre-visit planning or huddling was the key to a relaxed day and superior population-based care? And technology was a gateway to better and effective care and not a barrier. That's kind of probably thinking I'm smoking dope or something on that one. But what if, aside from the indicated physical exams and pap smears, PCPs never did prevention, screening, or routine care, but could prove that their care was really in the 90th percentile, the care of their team was 90th percentile nationwide? What if your typical patient encounter was focused mainly on your relationship and tackling interesting and diagnostic challenges? And finally, what if you loved coming to work? What if you as a provider, what if you as front office staff or an MA or a nurse loved coming to work every day, no matter who was on your schedule? So this is my interpretation of the future of exceptional care, from the viewpoint of patients and from the viewpoint of office staff. So patient-centered medical home, and we're going to digress to that just for a moment, is connected to exceptional care, and I call it the mojo, and mojo kind of means magic, right? It's a thing that really makes it happen. And just to put this to rest, patient-centered medical home has been talked about popularly for 6 years or so, 7 years, and the evidence is overwhelming. Better care, better prevention, screening, better experience for providers and patients at lower cost. The evidence is overwhelming from pilots across the nation, including the one in that third world country called Colorado. So the connection between PCMH, meaningful use, and exceptional care, I'm going to talk about 2 simple rules. And these are kind of guiding principles. These are 2 simple rules that are really just about all you need to know about meaningful use. And so when I'm done, I really encourage you, after you learn this, because it's really going to be very enlightening, not to just to leave and go home, because you don't need anything else to learn today, so bear with me. The first one is patients are persons first. Patients are persons first. Now that's a real dud, unless you start really thinking about it. And I started thinking about it, and I realized that for 23 years of my professional experience as a family physician, I didn't really understand that rule. I understood it one day when I made, call an uncalled for house call. It was to my patient Jim. I had known Jim for 10 years. I thought he was a peach. Real great guy, beleaguered by multiple medical problems, obesity, diabetes, dyslipidemia, depression, the usual stuff. And over the years, he seemed to just be deteriorating, and he was becoming more and more non-compliant with the kind of care I was providing him. And then I learned his mother died, and I decided on a whim one day at about 6 o'clock, I was done with my office schedule, go out and make a house call. So I rang his doorbell and came into his house. And it turned out it wasn't a house. It was an apartment. And Jim was kind of disheveled, and it occurred to me that he really dresses up to come see me. It's not how he usually was. He was poor. His house, his apartment was disheveled as well. I asked to kind of check out his medications, make sure he's taking them like he should be, and I was walking towards his bathroom in the corner of the room, and he said, "Doc, here they are." He handed me the bag, and of course there were bottles from 10 years ago and meds that he hadn't been on for a long time. It really not clear to me or to him what he was supposed to be taking. I was pleased he was taking his medication for depression. He hadn't seen the behaviorist I'd referred him to. Turns out he couldn't afford the copay from a year ago when I made the referral, and he no longer had a car. He also had a bunch of empty booze bottles around his place, and he didn't have any support. His sister was miles away, another state, and hated him. So this was an eye-opener, and so the translation of this was for me. I very rarely did house calls. But I did this for some reason or other. And the translation was that I don't have time to make house calls, to go out and meet the patient where the person is. Jim had tremendous economic barriers. He felt powerless and disengaged. He couldn't get to the behavioral health, which was really critical for him to help him with his mother's passing and his baseline depression. He wasn't eating well, he was drinking too much, and he had a terrible social network. And so what was stunning to me, the eye-opener, the beginning of my journey, was that I was great at his sick care. I was great at meeting him as a patient and understanding him as a patient. And I was really not good at understanding him as a person. And understanding him as a person makes all the difference in the world in terms of how effective I might be able to be. The second rule, number 2, is we're in the business of healthcare. Business of healthcare. And that's another jaw-dropping moment here. I'm glad you guys are stunned. But it really is to draw the distinction between healthcare and sick care. And I know a lot of you are already familiar with this notion. But it's really important, and it really is what exceptional care is all about. Exceptional care is health care. It's not sick care, okay? It's sick care too, but it's building on the sick care, building it, making it into something that is much more profound and expansive, connected with your communities. I'm going to relate this to you through the Los Angeles Police Department. Some time ago I was thinking about a motto to express the difference between sick care and health care, and I thought of one, and I looked it up, and it turned out to be connected to the LA Police Department. It was a motto that was created in 1955, and it was not this one. This was the problem at the time, to arrest and to incarcerate. In 1955, LA Police Department wanted a different image. And so they had a contest, and they got some interesting mottos. We call, or you call, we brawl. In God we trust, all is suspects. And we'll kick your butt and take your donuts too. Fortunately, none of those won. An officer, Joseph Dorobek, won, and he came up with one you'll recognize: to serve and protect. To serve and protect. And I thought that was pretty cool. In those 4 words means community orientation, it means attention to safety, and it talks about teamwork. What was stunning to me was on the website, and you can look it up for LAPD, at the top, to serve and protect, and then there's a scrolling motto. It says, to serve and protect as a team for my family, my community, and my country. And so that is the kind of quantum leap, the paradigm shift I'm talking about between going from sick care, right? Our motto, typically and traditionally and currently, most of the time, is still to diagnose and treat, to arrest and incarcerate. We need to move towards to serve and protect. So what does that mean? It means that even patient-centered medical home, as tremendously powerful as it is, has to actually evolve beyond that, beyond patient to the person, and beyond the medical model to the health model. So in order to be an Evelyn Wood's speed speaker, I'll run through this pretty quickly, but so it's the care of the patient and the person in their context where they live. It's contiguous accountability, not only at the time of the office visit, but the other 99% of the time when they're not in the office visit. To create meta teamwork, and I'm not going to go into that, but really sophisticated teams of care, and you'll see that a little bit later in a couple minutes. And then to include the patient as a meaningful member of their own team care, and also the development of team care within your office. Examples of this: group visits, population management, that kind of thing. So the last bit of my presentation here is about my second patient, Ruben, and what I call Ruben's message. I kind of am proud to be, I think, a very good clinician. And, I have stacks and stacks of New England Journal medicines downstairs in my basement from 30 years to prove it. But this is how effective I have been for years with Ruben. And this is his a run chart of his weight you have to look at the details. His weight, about 300 pounds, and his hemoglobin A1C, control of his diabetes, both of which are in poor control. So year after year, no matter what I did, the counseling, whatever, referral to dietitians, meds, I didn't make any difference with Reuben. And this was frustrating to me, and a number of my partners had similar frustrations, as you all do with some of your folks who are hard to treat. And one day, Reuben came in to see me, and this was kind of another watershed moment for me, and this was a few years ago. And, he's 60 years old, diabetes, hyperlipidemia, obesity, coronary artery disease, and I've got a 30-minute visit. So I'm kind of sweating at the beginning of the visit. Great guy, I love him, we've got a lot of things in common. But I'm trying to figure out how I'm going to do all this, and he says to me this: by the way, I have a total knee replacement scheduled in 2 weeks. And so for any clinicians in the audience, you know what that feels like, and your heart sinks, and you're wondering, oh my God, I can't send him, I can't reschedule him, I got to get this done. This is terrible. So my practice, other leaders with my practice, and I went to a resource, kind of like Beacon is and other organizations in the Cincinnati area, called Colorado Clinical Guidelines Collaborative, now known as Health Teamworks, which is a not-for-profit healthcare improvement organization for practices in Colorado, and got practice coaching on how to transform our practice. We got onto the PCMH pilot. We created performance improvement teams. We learned how to mine data in our practice and how to do change management and workflow mapping and all this stuff. And over a number of years, we incrementally evolved our practice. This is a picture of our performance improvement team. We came up across a barrier, though. Even after all of that, we looked at how we cared for diabetics in our practice in aggregate. And we had, at that time, about 423 in this slide. And looked at those diabetics that were out of control, and month after month, and really year after year, we just weren't making any progress with our diabetics. And we considered that part of the reason is cultural, that we have systems that are embedded in our culture that prevent us from really being effective with people with chronic disease. And we decided to try something really crazy, and that was the group visit. And group visits are truly crazy. They're really nutso, but in a good way. For one, they are, when they're well done, they're not led or conducted by physicians or even a provider. In our case, there are 3 MAs run our various group visits. They're not didactic. They're not something where you come and you have an agenda and you are teaching your diabetics on how to do foot care or their diet or exercise. They're facilitated, and the knowledge comes from what I like to call wiki learning. So the facilitation by MAs it kind of elicits the actually deep and profound knowledge in the patients in the room. So 8 patients have enormous experience and many very effective things to teach each other. And then, of course, group visits are empowering. People with chronic illnesses are often feel very disempowered because they just often get sicker and they don't feel like they're in control. In a room with other people with the same experience, you begin to learn that some people have figured out how to get a little power, feel able to control their own destinies, have things they can share. So group visits are a very powerful method, changing the culture, I think a characteristic of the quantum changes in exceptional care that can be really effective. So how effective? In this case, this type of exceptional care, this is, you don't have to get down in the weeds in this one, but this is 18 months worth of data for our group visits. We have 2 of them that we conduct on a regular basis. And the kind of bluish bar there, each one of those sets of bars is a different patient, and the blue is the original hemoglobin A1C. The higher, the worse it is, worse blood sugar control, and the maroon is the blood sugar control at the end of 18 months, so before and after during the period of time of the group visits. And those 2 brighter bars at the end, the red and the green, are the averages, average improvement. Bottom line is that the group visit, this element of exceptional care, really dramatically improved the diabetes care. And it did so in a way, for the clinicians in the audience, you can't do with a single medication. It's very difficult, particularly for difficult control diabetics, to do this otherwise. So let's wrap up here. Reuben's story. What about Reuben? What happened with him? Over a period of actually about a year and a half, his weight dropped 70 pounds, and his A1C, his control of his diabetes, improved dramatically from 10 to 7. And I wondered what was that all about? What worked good? And it's kind of like a dangling participle, I think. So there were a number of things that worked. Actually, this photo was taken at the end of his journey, where I was perfectly pathetic, doing absolutely nothing to improve his care. I had my MA take this picture because I was so thrilled to see him looking skinny and happy. Really exciting stuff. And so this is the same run chart I showed you before. His weight, blood sugar control, just not great. And then something happened in July 2009. I put medical home there just as a placeholder, but it really means that that's where we started to make headway on exceptional care, on the systems, the teamwork, the quality improvement, the health information technology, the cultural changes, the different techniques that we have put in place at our 14-person practice. And you'll see what happened there, how that changed and impacted his care. For all of our diabetics, we began to see a similar thing. Our average control or out-of-control diabetics was about 19% of the population, and now it's down to 14 or 13%. All of these things, all these exceptional care types of interventions make a big difference. So thanks for bearing with me in my journey. I'd say that we're about halfway there, even in Colorado. But it's exciting. One thing I didn't touch on was that changing the anatomy and physiology of office practice does something very interesting to the work environment. What it does is it creates new meaning of work. Not only for providers, because at some point we will not have to see 25 patients, but we will be focusing on really the sickest of our patients, but also for people at the front desk or MAs, for a person who doesn't have a college degree who is managing our diabetes registries or tracking ordered mammograms to make sure they're done. And when they see that what they do directly impacts the well-being and health of patients, they have a different perspective on their job. They enjoy it. They find it rewarding and very powerful. So we're going to end with a quote from this famous philosopher. Somebody has got to do something, and it's just incredibly pathetic, has to be us, and I think it's actually incredibly fortunate. Thank you very much.